All right, everybody, I think we should start. Let's start turning on our cameras and pay attention for Javier, who will be presenting after the report. So whenever you're ready.
All right, everyone. Good afternoon. We're going to start the presentation about this afternoon report. It's called Looking for the Source. So we have a chief complaint. It's dark emesis and rectal bleeding. And it's a 92-year-old male patient who comes in from the nursing home. He presented with bright red blood per rectum and 2 episodes of dark emesis since yesterday. In the HPI, we got, he's a 92-year-old male patient. He has a past medical history of high blood pressure, hyperlipidemia, CKD, CAD, BPH, COPD, and dementia. He presented with dark emesis episodes and bright red blood per rectum seen in the nursing home. He states that his dark emesis episodes started after drinking chocolate milk. After that, he vomited on and off and has not been able to tolerate any PO since then. He denies any fevers, any chills, any general malaise, lightheaded, headache, shortness of breath, palpitations, chest pain. He also denies any abdominal pain or changes in bowel movements, denies seeing any stool with blood or any black stool. The pertinent past medical history we have, well, as I mentioned before, he has high blood pressure, hyperlipidemia, CKD, CAD, BPH, COPD, and dementia. Family history is not contributory. Social history, he denies any alcohol drinking, denies any tobacco use or any recreational drug use, lives in the nursing home. The medications from the papers that we got from the nursing home show that he takes tamsulosin, risperidone, PRN when he gets agitated, sodium tablets, atorvastatin, and memantine. He doesn't have any allergies. In the review of substance, it was negative, except what was stated before. And once we get to the physical exam, we notice how his blood pressure was, on presentation, 93/61. His pulse was 67, then he became tachycardic to 113. He had a respiratory rate of 18 and an O2 sat of 98 on room air, and his temperature was 98.2 Fahrenheit. His weight was 71. And generally, he didn't seem to be in any acute distress. He was comfortably lying in bed. He had dry oral mucosa, and it was noted that he had some milk chocolate colored sputum noted in his mouth. On respiratory, it was clear to auscultation with no added sounds. In cardiovascular, he was tachycardic. His heart sounds were regular, and he had an S1 and S2 with no murmurs. The abdomen was diffusely tender to light and moderate palpation, and it was worse on the right side than the left side. It was negative for a Murphy sign, it wasn't distended, and he had bowel sounds. In the extremities, there was no lower extremity edema, and he had bilateral pulses. Neuro-wise, he was ANO ×2. He follows commands, cranial nerves were intact, and there were no focal motor or sensory deficits which were noted.
Let's just pause once and see if anybody has any questions about the history or the exam. Any other questions you would want to know, anything you want to confirm, or any other physical exam signs you are interested in knowing?
Any history of shortness of breath before presentation, or was he diagnosed with anemia on the regular labs that he had from the nursing home?
No, there wasn't any history of shortness of breath or no history of any anemia.
Has he been on anticoagulation recently? I know it doesn't seem to be on anticoagulation on the medications, but was he before it and then it was discontinued? Or
No.
any aspirin?
No anticoagulation, and there was also no history of aspirin despite that he was taking, he had CAD, but in the papers from the nursing home, he wasn't on any aspirin.
Or any antiplatelet, no Plavix or?
No, nothing.
Okay.
In the chat, Frida is asking if any history of prior GI bleed, prior EGD or colonoscopies. Chris Gold is also asking history of previous GI bleeds. And Kiran is asking if a rectal exam was done.
No, there was no history of any prior rectal bleeding. There was a rectal exam which was done in the ED, and it showed just brown stools. No, there was no noted, like no blood which was noted, or like dark stools. And there was no history of any prior EGDs or any colonoscopies that he had done.
Then Frida asked for NSAID or anticoagulants, which we answered. Anything else? All right. So as of now, most people are focusing their.
Oh, I have another question. I think I missed. How was the vomiting? Was it frank blood or it was like coffee ground?
So it was noted to be dark. One of the papers from the nursing home was describing it as coffee ground, but there was no clear signs of like any coffee ground vomiting and nothing like on the physical exam, which was noted. Just this like milk chocolate colored sputum, which was seen on
Okay.
the physical exam.
I see. Was this something that was sudden, or was he noticing that there was a change recently on his stools before it was like bright red blood per rectum? Like, was he seeing any melena, black stools?
No, this was all suddenly. It happened like a day before presentation to the hospital. It happened in the nursing home.
Okay.
Let's move forward now.
All right. So we got the CBC. The CBC showed a hemoglobin of 16.2, a white count of 20.2, platelets at 254, creat was 53, and the neutrophils were 85%, and lymphocytes were like 7.1%. On the chemistry, we got a creatinine of 3.69, BUN was 47, sodium was 144, K 3.8, CO2 was 23, and glucose 148. Calcium was 9.7, alphas was 105, LFTs were normal, troponin initially was 0.42, it downtrended to 0.39. We got a BBG, the pH was 7.3 with a lactate of 6.5 and a PCO2 of 59. And we also got a UA. The UA, the appearance was cloudy, there were proteins, glucose was 50, there was like a small amount of blood, nitrates and leukocyte esterase were negative, WBCs were 9, just one RBC, bacteria were rare, and there were also hyaline casts seen in the urine.
Let's take a pause and see if anybody has any questions or comments on the labs. In the chat.
Yeah.
Chris,
Any history of CKD before, or like is this just to make sure that this creatinine is normal?
There's a history of CKD. Yeah, I said that before. Yeah. His
Oh.
baseline creatinine was around 2.9 to 3.2.
Okay, sounds good.
and in the chat, I think Fatma's history of EGD or colonoscopy is none. Never had a EGD or colon. Then Joe asks, blood red bleeding per rectum happened before coming to the hospital. No signs of blood when he came, right?
Yes, it happened at the nursing home. That's that and the dark emesis. Those two were the reasons why he was brought into the hospital.
Okay. And then Chris says this hemoglobin seems concentrated. Kiran says you can hold the sodium tabs.
Any like any history of falls, recent falls, any trauma?
No history of trauma or recent falls.
The
The lactate was pre-IV fluids.
Okay. All right. So a few things, right? A few things going on. The patient came in with some, concern for a bleed. Clinically, slightly blood pressure was slightly on the lower side, tachycardic. But on the labs, what you see is a different picture, right? You see the hemoglobin is 16, but what you see is the patient has a high lactate. So kind of non-specific. Patient also had some non-specific vomiting. You can't clearly say whether it's a brisk bleed or there's no signs of a patient being hemodynamically. If the patient was hemodynamically unstable with almost at the state of shock from a bleed, you would have seen some manifest either bright red like hematemesis or melena. So the clinical picture is kind of not that clear, and the labs, the things concerning on the labs are lactic acidosis, and apart from that, slight there's a leukocytosis. So not very clear what's going on. So I think we need more data. So in the comments, Joe says anandap is too high for a lactic acidosis of 6.5. Correlation between what the lactic acid level is and anandap. There is some there's some formulas to calculate it, calculate how much should be the anion gap for what level of lactate. Not very great tools. So there's, but potentially some other kind of acidosis going on. This patient also does have CKD, so could be acidotic from that. But Dr. Singh says he's septic. Yeah, definitely meets criteria. We'll talk more about it in a couple of seconds.
Oh, one more question. Any history of abdominal pain, like before his presentation, like before he drank the milk? Like, was he complaining, like, I have been having this abdominal pain for a while, like every time I eat or anything?
No, no history. It's just abdominal tenderness upon palpation.
Okay, thanks. Do you know on the physical exam, was he like lying still, like he was barely moving, or he was like moving and then when you touch him, it was like tender?
He was comfortably lying in bed. Just when you palpate the abdomen, it was tender.
Okay.
All right, let's move forward.
All right, anyone wants to try the pollen representation for this case?
I give you 5 seconds before I pick somebody.
I mean, I can do it.
Okay,
So I
ahead.
forgot like how old is he?
Very old.
Sorry?
92.
Oh yeah, so we have a 92-year-old man with past medical history of CAD, hypertension, dementia with baseline AAO times 2, CKD baseline creatinine of 2. He is presenting with a sudden onset abdominal pain, coffee ground emesis, and bright red blood per rectum for the past 2 days. And patient on the labs very significant for vital significant for hypotension, lab significant for severe anemia, lactic acidosis, and high anion gap. And his presentation is concerning for acute blood loss versus sepsis. Yeah.
Chris, so he didn't present with any abdominal pain. So he didn't have any abdominal pain on presentation, and his hemoglobin.
Oh yeah, it's true. Yeah, it's on the physical exam. My bad.
His hemoglobin, he's not anemic. So let's go back to the labs. His hemoglobin.
Oh no, it's 16.2. I forgot that too.
Yeah. So,
like I know like that's not real. It's like concentrated. If you give him fluids or something, it's not going to be that. But it's true. I forgot his hemoglobin was everything.
So even if it's concentrated, it's not going to go from 7 to 16, right? It's like a couple of points of hemo concentration. So you're not really seeing somebody who's anemic. So what we see is, patient who comes in with non-specific signs and symptoms, some minor elderly patient with, some non-specific signs and symptoms like vomiting, no clear abdominal pain, and some minor right blood per rectum. So yeah, you can't really put this all into one clinical picture. He definitely has sepsis, but at this point, I would not, label him as acute blood loss anemia. I would say right now he has some non-specific GI findings as well, and then seem to have sepsis. And to label it sepsis, you need a possible source, right? So given his exam findings, he's not hypoxic, so it doesn't seem like a pneumonia. He doesn't have any rashes, so you can't say it's cellulitis. Neurological examination was normal, so as of now, based on my examination, I just see abdominal tenderness. So I would say, if I had to have a suspected source, it would be abdominal, given that he also had nausea and vomiting as well. But we can see Javier's problem representation.
All right, the way that I put it, just like an elderly male patient, multiple cardiovascular comorbidities. He came with the nursing home. He had acute rectal bleeding and dark emesis. He was found to have like serious criteria with hypotension and tachycardia. And he was also admitted for management of like possible sepsis given the white count and also further workup. No history of like no workup for anemia because the hemoglobin was fine and the rectal exam was just showing just brown stool. All right.
Can I just ask a quick question? Did anyone else at the nursing home have any symptoms, or do we know?
No one else at the nursing home had any symptoms. It was just him. And I mean, the papers that we got from the nursing home, they're not very specific, but as far as we know, no one else had like any similar symptoms.
Excellent question, Kiran. Can you tell us why you're asking that question?
Well, because if we're thinking of like more like dysentery, if he's septic and a GI source with bloody diarrhea, then it could be, like food poisoning.
Dysentery, or what other things can nursing home patients have? Nursing home patients nursing homes are notorious for GI outbreaks, right? So they can have some viral GI illnesses, as rightly pointed out by Feed on the chat. C. diff, Dr. Singh says norovirus. Yeah, so that's in ships and nursing homes as well. So, these things are usually seen in outbreak settings and not in one patient. C. diff might be seen in one patient, but but norovirus would be seen in an outbreak. So it'd be nice to know if other people around him had it or not. All right, thanks.
All right, so we got some further studies that were done on the patient. We started with the X-ray. The X-ray was showing no acute lung pathology, and there was no evidence of vascular congestion. We got a CT abdomen and pelvis, which was done while he was still in the ED. There was no evidence of active contrast extravasation in the upper abdomen. There was moderate gallbladder distension without any gallbladder wall thickening, and no intrahepatic biliary ductal duct dilation. And we also got an EKG, which was showing just sinus tachycardia, no ST elevations or depressions. If we look over here, you can see like how the gallbladder is like very, very distended on the left side. And also, well, you can see like on the right side on the coronal plane, you can see that as well. And there was no active extravasation of the contrast material.
So there's a question from Chris in the chat, which says any stones, any gallstones. So Chris, this is a CT scan, right? So do you know which stones you see in the CT and which stones are not seen? So the question is, do you commonly see gallstones on CT scans, and what's the most common gallstone?
I know that like the CT is not the best study for gallstones, but I was just wondering if they could detect any. I know like for kidney stones is better rather than gallstones. You will see them on an ultrasound, but I was it's just a question I had if they could see any.
No, so I just want to take this opportunity to talk a little bit about stones. So gallstones, the most common etiology is cholesterol stones, right? So those are the classic mnemonic is FFF, fat female fertile who's over the age of 40. So these are, cholesterol gallstones, which are not seen on CT scans. They're visible on ultrasound, but on the gallstones you see on CT scans are calcium gallstones, which are much more rare, and they're seen in patients with, biliary infections, parasitic infections. Those are stones you see on CT, but the modality of choice for the majority of stones is MRCP, and those are the on an MRCP you can delineate the biliary tree. You can see which stones there are. Ultrasound is slightly better than CT, but not as good as MRCP. And renal calculi is because they're all usually calcium oxalate. Those are the ones you see on CT. But what you will see on a CT scan is you can still see the biliary tree. So you can see if there's biliary dilation. That can be an indicator of there's potential patient who comes in with abdominal sepsis, there's biliary dilation that could potentially be cholangitis. So you're looking for dilation rather than a stone in a CT.
All right, I'm gonna continue over here. So I just wanted to this is a schema that I got from Clinical Problem Solvers. It's actually very helpful when you have that patient that, in this case, he was presented with tenderness to palpation. So I just wanted to show this over here, that you always got to think about if there's something that's life threatening. In this case, you got to think about an infarct, which is vascular. But usually those presentations are the patient would have a lot of pain, and then on the physical exam there wouldn't be any tenderness to palpation. So that's the classic thing that the symptoms doesn't correlate with the physical exam. If the patient was also perforated, then the patient would probably have rebound tenderness, rigidity, and the patient then would have been would be an surgical emergency. And when you think about obstruction, you think about SBOs when you're thinking if the patient having nausea or vomiting, which he wasn't having, or if you're thinking about large bowel obstructions, you think about distension, and you also think about cancer. And the way that I like to think about when you are examining a patient's abdomen is I always like to go with the anatomic approach. And that's when you divide the abdomen in quadrants. If you think about starting from the right lower quadrant, if there's tenderness over there, you most always think about appendicitis. If you're thinking about tenderness in the right upper quadrant, you got to think about liver pathology. Either it could be inflammation, congestion, infiltration. You also got to think about biliary, which could be any colic, cholecystitis, or cholangitis. In the epigastrium, I like it that we can think about GERD, gastritis, gastroparesis. We can also sometimes think about pancreatitis. And in the left upper quadrant, the spleen, any increase in size, any infarct, or any splenic abscess. in the left lower quadrant, we think about diverticulitis. And like in any of the quadrants, we always got to think about any colitis. If the patient's having like an infection, IBD, any infiltration, or any constipation. So this is like how I like to think when I'm examining a patient and I'm trying to look for like tenderness on the physical exam. So I'm gonna continue with what happened with the patient once he was admitted to the floor. So like on day one, of course, we sent cultures and we started broad spectrum antibiotics. We started him on IV fluids and his blood pressure actually improved a little bit with the fluids. On day three, the abdomen continued to be tender only on palpation. He wasn't complaining of any abdominal pain if you didn't touch the abdomen. His mentation was well. The white count was still like in the 19s. He came in the 17s, sorry. He came in on the 20s. The lactate came down. It was 2.35. That makes us think that whatever it was, at least it responded well to the fluids and to the initial antibiotics because at least we saw like a decrease in the lactate. And then 5, the physical exam was still unchanged. He was comfortably lying on the bed. It's just that when you examine him, he would still complain of the right upper quadrant, tenderness and palpation. This time we got an ultrasound abdomen because he was admitted over the weekend, and then like we managed to get the ultrasound like over the week. The ultrasound of the abdomen showed that he had like a moderate amount of sludge, but no calculus is seen within the gallbladder. The gallbladder itself is normally distended, measuring up to like 5.1 centimeters. There does appear to be diffuse wall thickening, measuring approximately 0.5 centimeters, but there was no sonographic sign of Murphy sign, and findings were consistent with chronic cholecystitis. The lactate was also improving and the LFTs were within normal limits. So after we got this ultrasound, of course, on day 6, we consulted surgery for the management of like the chronic cholecystitis, given the patient was still complaining about right upper quadrant tenderness despite being on antibiotics, and the WSBCs were persistently elevated and the blood pressure was like in the 100s for like very tenuous. They said that he was a poor surgical candidate, and he continued to have abdominal pain. We got an x-ray of the abdomen, and the x-ray of the abdomen showed that he had an abnormal bowel gas pattern with findings suggestive of ischemic or infectious enteritis with early small bowel obstruction less likely. So this is where things got a little bit complicated because initially we got this ultrasound, which was pointing more towards a chronic cholecystitis pictures. And now, given that the pain was not improving, surgery didn't want to do anything. We got the x-ray of the abdomen and now it's pointed more towards an ischemic colitis process. On day 7, after we got that ischemic colitis, we consulted IR. IR said no intervention, low concern for any gallbladder pathology, likely improving mesenteric ischemia that the patient was having. That night, he became hypotensive. His blood pressure dropped to like 85/48. He got more boluses and the antibiotics were also broadened. He was on ceftriaxone and flagyl. Now he was also on cefepime, and the WBCs went up to like 19.
Javier, Dr. Osorio is asking if there was any bowel movements during this time?
During this time, he was having bowel movements, but just a small amount of like bowel movements per day. He wasn't eating that much either.
And Dr. Singh asks, no HIDA done so far?
No HIDA scan so far. On day 8, then we got, given that he was hypotensive when we came back in the morning, we had to repeat the CT abdomen and pelvis because we either had a gallbladder versus a probably like ischemic bowel process that was ongoing over here. And both services, IR and surgery, they were saying that one was saying that the patient was a poor surgical candidate, and the other one was saying that they wouldn't do anything for the gallbladder, and they were having like a low concern for the pathology. So I want to ask you this question, like, what do you think is the source at this point? Do you think it's more likely something with the gallbladder or something undergoing right now that's going with the bowels of the patient?
I think it might really help, Javier, if you like describe like a day 7, day 8 exam, you know, when you're examining his abdomen, what does it feel like to you? And I know that Gina just asked, but like, what's the status on his appetite? How is he eating and drinking? You know, how are his bowel movements?
So he's having appetite. It's just that he's an elderly patient and he was requiring like assistance with feedings on the floors. And he was just eating like a little bit because he was telling us that when he was eating, then the pain might come and go. So he was trying to avoid it, but like with the nurse, he was having some assistance with it, but not much. In terms of the physical exam, he was very comfortable in bed. The only thing that he still complained was when you palpated the abdomen, especially the right upper quadrant, he would almost jump from the bed. It was very, very, very tender. And on the left side, it wasn't as tender as it was on the right side. In terms of bowel movements, like I said, he was having like very, very small bowel movements. Not much was coming out of that. He wasn't also eating that much. And mentation, he was maintaining between like ×2 and 3. We know that he has a history of dementia, so we were not concerned that he was having like an altered mental status at this time.
And what hospital day are we in right now?
We are at day 8.
Oh, sorry. Thank you.
And no melena.
No melena whatsoever with us. And the rectal exam, it was brown stools, and whenever he had a bowel movement, there wasn't any mention of any bright red blood or any melena that was seen.
So what is he having, like one bowel movement a day? Is that it?
Like every other day, he was having a small bowel movement.
Okay. No diarrhea.
No.
Just to summarize, what he came in was, like what he was sent from the nursing home was blood from the stool, and this coffee ground or dark emesis. But when he comes, what you see is something totally different, right? He didn't have any bleeding in front of you. His hemoglobin was normal. But what we saw that he had search criteria, he had a tender abdomen, and he had high lactate. And you've treated him with, we've treated him for sepsis, but we don't really have a source. CT scans are, we haven't clinched something. There's one really, really important thing we haven't ruled out. We don't have a high-risk scan, so we can't definitively rule a cholecystitis out. But at the same time, his initial CT scan was negative, although it's not the best for cholecystitis. And we didn't see any cholelithiasis. So, surgery was consulted, and seems like there's nothing emergent they want to rush him to the OR for. But this is an elderly patient with you don't have a clinched diagnosis, which is clinching. So I would say there's a lot more questions than answers right now.
Yes, and the reason why we got that repeat CT abdomen that I'm gonna show later is that, well, he was hypotensive overnight, and he had to receive more fluids. So we knew that something was going on despite being on the antibiotics and despite being on fluids, which we're not addressing. So we had to find what was the source, because if we want to have control of sepsis, we gotta do like a source control, and we gotta look for it.
Can you go back one more time to the imaging slides? You had like a abdominal X-ray, and then you had a chest X-ray. Yeah, that one. So how are they making a comment on an abdominal X-ray about ischemic versus infectious enteritis? Like, what was the finding that made them, like, was the small bowel wall looking thicker?
I don't remember like specifically the reading about it, but I do believe they did mention about the bowels like being thickened, and they didn't see like any signs of like obstruction or any like dilation of like any of the bowels. So that's why they were not considering like small bowel obstruction at that time.
And that initial CT on admission had no comment on enteritis, like no colon or small bowel sort of wall thickening. The first one, day one.
It showed that he didn't have any contrast extravasation and that the gallbladder was distended, but nothing mentioning about the thickening of the walls.
Yeah, I would just caution, this is an overread abdominal X-ray, right? This is not the kind of read that I'm used to like seeing on an abdominal X-ray, right? So, how are they making a comment on ischemic or infectious enteritis? They don't know if the patient's having diarrhea. They don't know if the patient's having melena. It's overread.
All right, I'm going to continue over here. Now I'm going to show you the results of that repeat CT abdomen and pelvis that we got on day 8. And over here, if you look at the gallbladder, now we can see how there's this accumulation of fluids like 4.6 centimeter times 4.3. And if you look at the lowest left-sided image, you can see there's a loss of continuation of the gallbladder wall. That loss of continuity makes us think that the patient was perforated. And if you see on the coronal plane, there's also this huge collection that's on the right side of his abdomen. It was measuring like 13 centimeters, which these were new findings. These were not present on the initial CT that he came in, and nothing was also shown on the ultrasound that we got on the patient, and also like on the X-ray. The official read that we got on the diagnosis on that CT showed that he had gangrenous cholecystitis with focal discontinuity of the gallbladder wall, continuous with that subcapsular hepatic rim-enhancing fluid collection, and the additional right upper quadrant intra-abdominal abscess, which measures up to 13.7 centimeters, abutting the anterior abdominal wall. So now we're here, we finally, if we think about it, the patient initially presented with that chronic cholecystitis. The no surgical procedure was addressed, and then the patient overnight became hypotensive, got more fluids, and then on the repeat CT scan, now we know how this patient developed a gangrenous cholecystitis and this intra-abdominal abscess, which was measured like 13.7 centimeters.
Javier, before you go ahead, just in the theme of like the reads on imaging studies, that other read that you had, which had commented chronic cholecystitis, it's another thing that's overread. How are they making a judgment call on acute versus chronic? And I'm just saying, I'm cautioning because, as the clinical team on the floor in front of the patient, especially when physicians are in training, right? They're looking at these reads and really relying on them, right? You read it and then you kind of embrace that diagnosis and run with it instead of, kind of going back to your bedside and saying, does this fit?
That's why we consulted both services. We consulted surgery. Surgery was saying that if there wasn't like any other source other than this chronic cholecystitis that was shown on the ultrasound and the white count was persistent elevated, they were saying that it could be chronic cholecystitis, but they wouldn't give us like any final diagnosis. Then IR also like dropped in and they were saying they were not thinking that it was a gallbladder pathology, and they were just saying that it was likely improving mesenteric ischemia. They wouldn't and I believe like IR, they're supposed to be also looking at the images. At that time, we had the abdominal X-ray. We also had the initial CT and the ultrasound. That's why we didn't know exactly what was the source at the time until we got the repeat CT abdomen and pelvis.
So yeah, I would say my take-home message is that LLE patients, especially with sepsis, can present in very subtle ways, and intra-abdominal sources for sepsis, you need to know what is the definitive way to diagnose them. And this is a patient in whom acute and chronic cholecystitis should have been on the differential. And if you called it the appropriate thing, you called surgery, the way to definitively rule out acute cholecystitis is not a CT scan or an ultrasound, it is a HIDA scan. If this patient would have had a HIDA scan, I think the acute cholecystitis might have been caught earlier, and that would have prevented this infection from worsening into a gangrenous cholecystitis and then becoming an intra-abdominal abscess. So you have to know what your differential is, and based on that differential, you get the appropriate investigation. A CT scan will not pick up every intra-abdominal source of sepsis or every intra-abdominal pathology. So even like within the abdomen, you have to know what your differential is. If you're suspecting mesenteric ischemia, a simple CT scan is not going to do anything, right? Then you need angiography. So based on your differential, you order the appropriate investigation, and we have this tendency of ordering a CT and then saying, okay, intra-abdominal pathology is ruled out. But that's not the case. Within the abdomen also, there's specific tests for specific pathologies.
All right, so I'm gonna continue over here. So the further management, like on day 8 after that CT scan, he underwent a placement of a cholecystectomy tube and also a right abdominal abscess drain by IR. They immediately took the patient to the OR and placed, to the IR site and suite, and then placed both drains. He continued with antibiotics. We were following cultures, all the cultures throughout the hospital admission, even the ones that were taken by IR during the procedure, they were negative. But we continued with antibiotics, and ID was following the case as well as the ICU team. And because like when he was taken by IR really wanted the ICU consult just so to them for them to be aware the patient had to be admitted straight into the ICU after the procedure, which was not the case. Something that really happened is that after the procedure, the abdomen stopped being tender that following day. And well, he continued to be in the hospital. And then on day 16, the abdominal drain was removed, given that the abscess on the abdomen was decreased in size and there was minimal output from that drain. So he was only left with the cholecystostomy tube. He was discharged on day 21 with ID follow-up and the cholecystostomy tube in place. So I just have over here this illness script for gangrenous cholecystitis, so we can just keep that in mind. The pathophysiology is that necrosis and perforation of the gallbladder wall, which results from ischemia and chronic vascular insufficiency in a patient. Patients that are at an increased risk are male patients, advanced age, patients that have delayed surgery, leukocytosis, and patients with cardiovascular diseases and diabetes. It's usually acute in days, and it gets progressively worse if it is not treated on time. And the symptoms and signs, it's usually right upper quadrant pain. You can get a Murphy sign. You can also have nausea and vomiting, shortness of breath, and right lower chest pain if it's also touching the right diaphragm. You also get rebound tenderness and fever and hypotension and altered mental status. The diagnosis, well, we get that the patient has to be leukocytosis with an elevated SRP, ultrasound of the abdomen, which is going to show gallbladder distension, wall thickening, and loss of continuity of the gallbladder wall. If you don't get it, then you can order a CT abdomen or an MRCP. This is for gangrenous cholecystitis. This is not for acute or chronic cholecystitis, which the HIDA scan would be appropriate. And treatment, we need to do antibiotics, and the first line of treatment is also surgery. In this case, our patient got a cholecystostomy because he was not deemed a surgical candidate given his age and his comorbidities by surgery. And I just wanted to touch base about when we think about an elderly patient, as we saw in this patient, sometimes the abdominal pain is not a direct and it's sometimes just very subtle, which can it doesn't tell you much what's really causing the pain or the presentation. So 20 to 30% of older patients with an active infection may have a blunted fever response. This is because patients elderly patients usually have a lower basal temperature and it takes longer for them to actually achieve a febrile episode. As we can see, our patient, he never had a fever. Pain perception is also less sensitive in geriatric patients, particularly in the abdominal disease or pathologic conditions. This is usually due to changes in the peripheral nerve functioning, which leads to a subtler presentation of pain. And also, geriatric patients are more likely to be on beta blockers, which may inhibit the tachycardic response in the setting of an infection or pain. In this case, our patient was not on one and he was tachycardic on presentation. And more than 20% of patients older than 75 are on some form of anticoagulation, which increases the risk of gastrointestinal bleeding. In the simile of mild trauma, this wasn't our case, but I just wanted to bring this up because as we saw with this patient, we knew that he was having right upper quadrant tenderness. It's just that he wasn't complaining of pain. He was just laying in bed comfortably, but he was also becoming hypotensive. So I just wanted to bring this up so we can always think about it, because when we think about our older patients, both at West and also in the Jerry service or at Morningside, we gotta have this into consideration that it might not be the same presentation as a middle-aged or younger patient. And specifically talking about biliary disease in the elderly, it's the primary cause of emergent abdominal surgery in the geriatric population. And gallbladder perforation, gangrene, and emphysematosus cholecystitis, ascending cholangitis, and gallstone ileus and cholecystolithiasis are more prevalent in elderly patients. This is because they have more years and more time to actually develop gallstones, which can cause these complications in these patients. And that is all about it. Thank you very much.
I think I'm looking at the chat, Ferris makes a good point as well, but I think the right upper quadrant pain, I see the reason for, or the concern for CTA with the history of this bleed, or everyone was kind of focused on the bleed when he showed up from the nursing home. But it's with this right upper quadrant pain at that point, I think all of us would have been why not ultrasound of the abdomen to look more at the gallbladder to see what's going on there. I was alluding also to like concern of C. diff, because for me, this patient at 90, I agree with Dr. Singh that he really did put up with a lot. I'm really impressed that at 8 days, we're finally getting a CT, but he's getting hypotensive, his white count's going up. He showed up with this lactate, and I'm really concerned, like, are we missing something? Like you said, what is the source? And I think for me, but it's all like retrospective, like we always say, that for me, it would have been maybe get an ultrasound, you know, when that ribocardioid pain, but again, it's at the weekend, like we don't want to be. And then C. diff is not ruled out if there's no diarrhea, because that's something that I get asked a lot when we're getting these approvals. So, because I err on usually the safer side, but usually like that's another thing that I always caution people, just because someone doesn't have diarrhea and in a lot of bowel movements doesn't mean that C. diff is ruled out. And that to me is also high threshold to kind of start severe treatment for C. diff. So that's, you know, but, you know, I'm glad, so he went back to the nursing home and.
Back to the nursing home, took in place and all that outpatient follow-up. Regarding Frida's questions, his initial CT abdomen on the ED was a CTA, and there was no active like extravasation, either like in the bowels or like from any of the vessels. So he did get that CTA.
No, and I agree with, I've been here for 10 years. That's always been my issue. I don't understand why we don't have ultrasounds on the weekend. These ultrasounds for DVTs, things like that. That was one of the reasons when POCUS became very popular. That was one of the reasons that the residents at that time were kind of advocating for some type of ultrasound, with the understanding. Then, you know, we all understand that POCUS is hard because you want to be certified, you want to be, you know, someone that's competent to do the POCUS. So that's always been, I don't understand, except for the fact that we always get told, oh, you can call if it's an emergency, which I don't know if any of you guys ever have gotten a tech to come in over the weekend. But that's what we get told too, is that you can call them if it's an emergency, but that usually doesn't happen. But I agree with what has been said about the ultrasound techs too.
I have a question, Javier. When you guys consulted surgery that first time, did they not recommend a HIDA?
They did not. They told us to reach out to IR. They were saying that given that the white count was elevated, that we had the ultrasound finding, which was showing this chronic cholecystitis, that they really wanted the patient to get a cholecystostomy tube at that time. It's just that when we told IR about it, they say, this is not the gallbladder. We reviewed the images. There's nothing to look over there. This is likely mesenteric ischemia, which is resolving.
So I had a very similar case a few months ago, and sort of similar hurdles with the weekend being in the middle. And finally, we sort of just pulled the trigger day 4 and said, we're getting a HIDA. This has to be acute chole. It's fine that we're not seeing on CT. It's fine that we're not seeing it on ultrasound. You know, people come in severely dehydrated and septic, and you don't always see that kind of gallbladder wall thickening, you know, sort of more definitive findings. And so the HIDA is what then convinced the surgeons to go ahead and act on it. And, you know, I think I wonder sometimes, I shared an article and because I look this article up all the time to figure out, you know, what is the best imaging modality when you're stuck with a patient like this? Because ultimately you have to go back to two things. When did that person actually get sick, right? They were doing okay, thriving at this nursing home, and then he gets sick one day, right? So there is an acuity to the event. And then, what is the only physical finding you're getting? You're only getting right upper quadrant tenderness,
Yes, that's
right?
it.
So there's an acute event and there's a finding, and then you just have to chase after it till you pick the right imaging modality. You know, and so sometimes, I mean, I can tell you with a very similar case, I struggled for 4 days before picking a HIDA and just, you know, getting on the phone with the attending surgeon and saying, no, this is acute chole. It doesn't matter what the radiologists are calling it. So yeah.
Yeah, I mean, during those days, like surgery said they would have taken the patient. It's just that he wasn't a surgical candidate, and they really wanted IR to put that chole tube. But then IR said, no, we look at the images. There's nothing to look on the gallbladder over there. Think about mesenteric ischemia, which is resolving.
And that night he perfs, right? Like when he tanks his pressure, he perfs. It's just tragic. I mean, this man's a warrior.
Yeah. So it was, I mean, that was like a back and forth. it happened like on the jury service, like surgery. They were sitting like in the room next to us. We were going to their room, and it was just difficult to actually get a procedure done for the patient. Yeah.
And where is mesenteric ischemia, even with that? Like, it just kind of was interesting. I think I know this case from ID perspective, because I think I remember him. But yeah, I don't even know where the mesenteric ischemia at that moment.
It's
you would
that
say.
over reliance on that X-ray commenting that there's enteritis. You know, it's that, and you've got to pull up the film yourself and say, what is it that they're seeing?
And the and then they just think, what's this rhipicardic pain? Just chronic cholecystitis? Is that what they're saying from his chocolate milk? Like, I don't know, like, you know, so I don't know. But yeah, it's a very nice case just from even like decision of imaging. And then at what point, and I think we always have this controversy about like CT versus ultrasound and when to have them done. So and then just the lapse and the fact that his age, we always talk about the younger population kind of putting up with a lot, but then the more experienced, because I don't like to say older, but don't repeat that to anybody, the more experienced individuals like this guy really went through a lot. So it was I'm glad it went okay at the end, even though he's suffered through a lot. Yes. Thank you.
Thank you, everybody. I think in the interest of time, we should move on to our next activity.